For everyone watching, the background to this is I released a video on forehead and whole forehead anatomy, which I think covered what a lot of people would, if you look into it, it's the anatomy you get taught. And I've been on training days when that anatomy is relied on very, very heavily, to the point where I once saw someone treating revolumizing the forehead with needle onto periosteum with a single bolus in the middle of the forehead and then massaging it out. So, so this is how, if you believe in black and white anatomy, that if there's some rule or whatever, that it's always that way, you can talk yourself into injecting that way, believing that it's a very safe place to put the injection. And then you sent an image. By the way, that's not how I teach it. But as I was talking about those principles of where the arteries were, you inboxed me with this picture of some anatomy where all the arteries are running exactly where they're not supposed to be. And that's kind of what tonight is about. So,
look, what I can tell you on that note is that please, first and foremost, don't shoot the messenger, okay? Don't shoot the messenger. Even the apocalypse messenger is still just a messenger. But reality is that it is remarkable. It's fascinating how we have a consistency on the existence of the anatomical structures. Everybody has this artery you're scared of, look, and me too. Everybody has, there is a consistency, and it's remarkable. The variation is on the location, the size of the structure, and I have so many anecdotes. When you ask me about the anecdotes, I say, oh my God, I wish I had, we had a chance to talk more about it, and I'm sure we will. But reality is that location, the size, and most importantly, when the treatment plan is exclusively aesthetics, the functional status, the status of the immune system of the area where we are planning to treat. So all of these structures, they are always there, but they will never be where we think they are. They're never going to be the size we have in the averages. And when you told me about the books and the way, reality is that we need the books. And we, both me and you and a handful of acquaintances we have in common, we work a lot to build this literature. But these courses that we take and that we teach, they don't reflect the amount of time it takes for us to feel comfortable with these structures. This is the reality.
And hopefully we can get to the, because I think that there's both have to play a role. We need to, like you say, we take the anatomy that we do know, what we do understand it, and you develop a working model, but then you have to inject in a way that you assume that the working model doesn't work. Like, so it's somehow both things, like a duality where it's what you believe to be true, but what if it's not true? You're trying to do both things.
Yeah.
So it's, which is why my example of injecting with a large bolus on the forehead is quite a good example, because if it was 100%,
out of curiosity, did it blank? Did it go blank?
No, it was fine. I mean,
it's amazing.
It expands and then you massage it out, and it looked, like a lot of these things, it looks easy. The first time you get taught these things, I remember being taught by a very famous injector about a long time ago, and they don't teach the same way now, but when you're injecting the temple, it's easy. And the catchphrase was, do it tomorrow, just bolus it in, do it tomorrow. And we obviously change over time because we become more conscious as complications are so much more variable. But also what I love is this variation in what you think to be true. I'm having it at the moment with ultrasound, because I learn these things and then I have an ultrasound and you're like, hang on a minute, this is not what I've been imagining for the last 12 years. And how lucky am I?
I get surprised every day. Reality is that we really get surprised all the time. And the trick is to learn how to deal with the frustration of finding structures where we are not where you assume they were not supposed to be. It is a very honest, loyal approach to what anatomy is supposed to be, because reality is that sometimes you just have to deal with what you find. And academically, we tend to summarize placement and location and size and functionality of structures in order to expedite the process, because the reality is that we are focusing on a technique, which is actually, by the way, something we control. I'm sure there are people that place large balls in the middle of the head, and they feel comfortable doing that because they've done it many times. So technique and material are pretty much what we control. What we don't control is that we need to have a more respectful approach.
I think, yeah, and the respect comes from the fact that you're trying to apply an average of anatomy, or maybe, as you said in the email you meant to me, a lot of the anatomy is based on a very few number of cadavers done a long time ago.
That's exactly what it is.
Yeah, and so but even if it was an average of all the cadaver, of all the anatomy, it still will not apply to the patient in front of you ever. So even if you have the perfect
Can I give
anatomy,
you an example? I might give you an example that is recent. So a few years back, I was approached by a group that was building a book on lip injections, and they requested me to perform 3 dissections and find facial artery in main distance to facial vein. So I performed a standardized access, like 2 by 2 inches access to find. And the 3 dissections that I was requested to perform had 6 millimeters between artery and vein, 7 millimeters and 8 millimeters. So it was published with an average of 7 millimeters. My homework, the due diligence that I did in order to find those structures in preparation for the book images, was that in the literature I found between 6 and 25 millimeters of distance between artery and vein. Fast forward later on this year, I've had to perform like 20-something cuts on mandible. So it was deeper anatomy. And because it was pretty close to facial artery and vein, I decided to extend a little bit a dissection, and I created another number, like the N for this particular measurement. I had more data. And my findings were between 6 and 16 millimeters in this amostrage, in this sample particularly.
6 and 60.
You see, so that would give me 11 millimeters average of distance, the main distance between artery and vein, which visually, when you look at these dissections, the one behind you, for an example, it has this kind of theme. Not a single one of the 22 was 11 millimeters distant of each other. Not a single one. So in what we need to publish, the standards of publication, is that the average of the sampling is 11 millimeters distance. Not a single one was 11 distance of the other.
I think that's a really good example, because you can imagine the distillation of that publication becoming that the artery is 11 millimeters from where it should be.
Spend 3 days with your group of students, and you bring up the facial artery, which you have to, because it's in an area that is trendy now. The mandible manipulation of volume of the angle is trendy right now, and then you bring this up, and because this is what you have in the literature, this is what your students are gonna keep in mind, and they're gonna feel the pulse of the artery. The vein runs a little behind. We have this statistics. And by the way, I love your posters. I use one of your posters very much because it's very realistic. It's a diagram, it's an illustration, but it's very realistic because of the sinuosity of the artery comparing to the vein that goes straight down. And this,
thank you. That's a huge endorsement from an anatomist. Thank you.
And another detail, I am not a degree anatomist. I'm self-taught.
Yeah.
I don't have training in anatomy, and sometimes I have my work compared to people, and my heart skips a bit because some of our colleagues, they pile degrees in anatomy, and I'm just curious enough to, and my experience, which is surgical. I spent 15 years pretty much just 100% clinical with my first lecture was 2008. I had never lectured before that.
Yeah. But you've got this experience now of actually doing studies, and it's time with a cadaver, thinking
that's what it is. Surgical access, patient and cadaver, pretty much. That's what it is. That's what it is.
So tell me some of the things that you see. Do you see injections on social media and think, oh, that scares me? Like, what are the ones that stand out to you?
No, like it lifts the hair on my neck. It does.
Which one?
It does.
Give me an example.
An example is when the upper lip is much taller than the lower. I think
Oh,
this
the
is
result.
against the natural appearance and the natural proportions of the face. Another thing is when I see procedures that try with injectables to correct deficient skeletal structure. And this we see a lot because immediately it gives you the illusion that it is compensating, especially on very young people. You see, in my opinion, and this is me oyolizing you, which is, I'm always gonna try to do that. But reality is that, in my opinion, there is no way to compensate deficient skeletal structure with soft material. Like big discrepancies on skeletal defect that many times need to be corrected either orthopedically or orthognatically, and fillers are not going to make up bone. They're not going to make up the skeletal scaffold and structure that bone, missing bone should be. Or when people try to build soft tissue on top of missing teeth, especially the posterior teeth, when the vertical dimension collapses because there is a closure of the facial angle, and they try to compensate this. This for me is almost offensive, to be honest.
Mm-hmm. Tell me, let's try and make it more specific for the viewers in terms of risk, for example, the specific area, for example. So in terms of treating the forehead, from what you know about the anatomy, what do you think the best approach would be?
There is a few things that we can do beforehand to bring confidence to the procedure, to the moment. And I think that feeling confident on your decision on treatment plan is essential because the patient picks on that. They feel that. If you don't really know if this is about. So there is a few things I do first. For an example, I ask the patients to bend over. Your poster is great. And I wish everybody had, you know, the idea of what I'm talking about when it comes to your poster, the arteries and veins. Because your poster shows that the venous vasculature rides slightly behind the arterial, and because of the display of the vasculature from cervical and up, we're most of the times, and always we have exceptions to that, but we can be confident that arteries run a little ahead of the veins. Mm-hmm. Veins are greenish under the skin compared to arteries, and arteries have pulse. So every time I see, for an example, tear through for supra or like intraglabellar area, and the patient bends over, if you see the pulse, you know the vein is right out off it. If you see green, you know the arteries is medial to that. And this kind of in case you really need to inject a volume that is relevant, because small volumes in first appointments, they are usually safe. But when you have a young patient that wants structural change, like topography remodelation, and it requires a little bit more volume, it is important to locate pulsations and vasculature that you don't want to disturb. So if I do like this right now, you're gonna see my angular vein pop up green in the corner of my eye. And if you see that, you know the artery is running right ahead, you put the finger, you feel the pulse, and vice versa. If you watch the pulse, you know the vein is running right behind. So these little tricks are essential when you need volume in areas. Older skin are more pinchable. You can literally palpate access to space in older skin. And if you can pinch, you have space. I have a preference for cannulas when it comes to designing, but I am confident on telling you that thin cannulas, 27G cannulas, are as pinchy as a needle is. And we need to be mindful of where is it that the outlet of the cannula is pointing at.
That's a great. I love the tip on the veins and the arteries, and that you can.
Bend over a little. If I do
Have a
it
good,
like this, and you can start seeing, especially because I'm a mom, so my veins need to be, you know, visual, because that's how I talk to my kids. So they pump, they already know that there is a message there. Isn't that, that's the reality. And this is very visual on people's, regardless of the color of the skin, you can always see a difference in shade when a vessel is underneath. Lid area, forehead area, especially young people, it's very thin skin. It's easy to see how much space you have in between. Vessels too, they have this spaghetti filling, and you can even push them and place your cannula underneath. One of the images, I sent you one of those GIFs. I don't know if you can bring this up, the GIF where you see the material in between the layers of in between the tunicas of the vessel. Because of my experience with dissecting, very small vessels are not easy to cannulate.
mm-hmm.
And I tell you that because there is no skin. I have a lamp, you know, sometimes a loop, and I miss it. A 2 millimeters thick vessel, it's not easy to run a needle within the tunica, the internal tunica. So most of the accidents, the vascular accidents we see, they're compressive. There is stenosis, like strangling the vessels through the outside. And also deposits of fillers in between the layers, especially between fat and the muscular layer of the arteries. There is still no occlusion. That's why we see partial necrotic patches instead of full necrosis.
That's an interesting idea, because one of the things I've often heard from surgeons is if you tie off a vessel in just one place, normally there are enough collaterals that it can supply around the other side. Is that...
Tim, I reconstruct vasculature. I tie big vessels. I can see people stop breathing around me. There is not one person breathing, because it's so scary when you slide a vessel 90 degrees against the flow and there's no necrosis. There's no necrosis because the collateral anastomosis, the vasculature, is free to be occupied by the counterflow. A cork of filler, nothing moves. That's when we see the difference between cutting a vessel and clogging a vessel.
So are you saying, well, if you clog a vessel, but it's only a short section, but you're still going to get necrosis somewhere? That's your understanding? And where would you, obviously, is that, how would you differentiate that from a very big emboli that kind of blocks? What does it look like differently? Those two pictures.
Let me see if I can pull. This one is the one I'm talking about, where you have a partial occlusion when the vessel is collapsed from outside in, because the filler deposits in between the layers. You still have some blood flow. This is your 5 seconds capillary refill against no capillary refill at all.
That's interesting. So this is that compression. Now, when I thought about compression, I often think about larger structures, but you're almost saying like it can just be right next to the artery, and
yes. We know we have at least an average of 4 vessels that outlet internal carotid to the surface of the face around the eye socket: dorsal nasal, supratrochlear, supraorbital, and zygomaticofacial, which is a terminal branch. It's usually not harmful even when compromised on the very final segment of it. These other 3 arteries, they usually have intercommunications with other arteries, either external carotid branches or collateral from the other side. Mm-hmm. And still we see spread of ischemic patch at a distance, and this is what explains sort of what happens when people get so shocked when they have an ischemic patch that reaches the middle of the forehead and an injection was happening in this in the fold.
Yeah. So that pattern for me, I would imagine, is because you've got enough blood, enough filler into that vessel that you've blocked a sizable chunk of it. So it's not, that wouldn't be one emboli here. It would be,
yes. So they're like partially you have this where the filler reaches in between the layers of the vessel, or you have just a compression from the outside, which is not, it doesn't require a lot of filler to compress a vessel that is 1.5 or 2 millimeters thick.
Yeah, that's a good point. So the GIF that you've got is an illustration of the concept. Have you ever kind of achieved that on a cadaver or seen it in an ultrasound?
I happen to have a finding.
Ah, right.
So this is a cadaveric dissection. This is a frontal branch of temporal superficial, which I know it's a sensitive subject for you recently because you found Miranda's artery away from where you expected it to be in the temple, yeah. Right? Recently, I saw something like that. And this is PMMA that was found. We had this examined to make sure that it was a permanent filler. And you have this picture, you look at it closer. I have a better quality resolution for this image than this that I have, that I'm looking at right now. But you see here, when I ran the contrast within superficial temporal, it ran through. There is no occlusion in this vessel. But I can sure tell you that this, either the filler itself, whenever it was injected, or the granulomatous growth that developed as a foreign body reaction of this material at some point. I don't know when it was done, performed, and how long it lasted. It sure lasted more than the patient did.
So there were no necessarily there were no side effects that you're aware of from that case, but there was some.
Know, but I can tell you that this vessel here has a vascular differentiation in the tunica, external one, because this material invaded in between these layers. Either the injection, which this will never find out, or during the inflammatory process of a non-reabsorbing injectable.
Mm-hmm. Okay, so does this, sticking on the topic of temples, what do you think is the better long-term approach for temples? Using a cannula more superficially, or the periosteal injections, which is one I'm most familiar with? What would your opinion be?
I think both are safe as long as the indication is proper. Periosteal, under the muscle, is an injection for people with Dolic, not as strong vertical profile. Because temporalis is a very strong muscle. Whatever you inject subperiosteal under this muscle, if this is a very strong muscle, is going to be moving on top of this filler. You cannot really guarantee that this filler is going to be in place. So strong brachycephalic people are not the first candidates for superiosteal fillers. Mm-hmm. Above the SMAS, you have consistent hollow space that can be filled. Now, the ligaments, the septa, between the septa, and I do have new pictures. I'll share them with you as soon as I have the go. I need to go through a diligence process in order to get access to these cadaveric images of the dissections that I perform, where you see the septa separating in areas. So when you run down a cannula in this area, you feel that it grips as it goes down, because the septa in the temporal area is not a one hollow space. We do have a few, and I have great images of that are brand new, and I'll share them with you as soon as I can. And this is what reflects the cannula gripping on the way down. So this one bolus deposit that we massage, this is not realistic because the septa, the divisions, like these areas that are divided by these intraseptal branches, they don't allow the filler to go down. This is also what happens with water when it retains on top of the ORL. We do have layers as foil though on this. The difference is that it has this aponeurotic display, which is a fan-like instead of the vertical display of the oral. There's still.
So let's go back to the nasolabial fold. A couple of questions about the analog skills, I sometimes call them. So it's not black and white. It's how it feels and how your style of injecting affects risk. Do you think a gentle injector can feel going through a vessel? Is it something that you would detect with a cannula?
Into a vessel, I find it hard to believe because the spaghetti-like movement of the vessel doesn't let you, especially arteries. While in residency, we've had to go through phlebotomy training, you know, and if anything, we are poking veins, which the tunica, the muscular tunica is much thinner than an artery. The arteries they tend to run off, but in between the layers, that's for sure. And I don't feel it when I do it. I don't feel the difference. It's not something, even when I'm watching without the skin and I'm getting between layers of a vessel, I don't think the feeling is relevant. That's not going to be easy. The patient feels though, because we have sensory response. And that's why I'm careful on recommending, and I would like people to be careful on doing full anesthetic blockages, especially when it has vasoconstrictor, which dentists do a lot because they have the ability of performing local injections, and they do have anesthetics with vasoconstrictors available, and they have ability to do that all the time. So we need to be mindful of different procedures, different preparation as well.
Okay. So I had another question on that. So if you, because I believe that with noses, it makes sense to me that cannulas are more likely to enter a vessel, and the bigger vascular occlusions that affect the ocular blood supply, I think there's an overrepresentation of cannula injections. But it's a niche space because it's such a small space. You're parallel with the vessels, and sometimes you're having to push quite hard.
Let me tell you something that a little bit more food for thought. These are three skulls. This is a Caucasian person, this is an Asian descent, and this is an Afro descent. When we are building a bridge on an Asian descent person, look at the size of the nasal bone compared to this nasal bone. We don't have a lot of support to build filler-based bridges and root of the nose area. When we determine that we are performing a procedure on an area that is small for support, we need to keep in mind how much bone support you have. Nasolabial fold is the same. The piriform opening is your medial limitation. And then you need to lift the skin because the shade disappears. Collapsing the ala of the nose, which is fatty tissue, it's not cartilage, against the piriform, that's not going to happen. It's not going to go within because you have a bony vault. It's an opening. So this is also another reason that I see filler moving towards the artery. Even sometimes on ultrasound images, you'll see the injector saying, but I was closer to the nose. How come the filler is over there? Because you're closer to a hollow bone entrance. The filler is going to bounce against the bony vault. So this is relevant because in this person, you have a fair amount of bony structure to support the reconstruction of the soft tissue. In here, you're very limited on structure.
Yeah. And you can, I always recommend palpating the nose before you inject to actually feel.
Of course. Exactly, me too. Especially because the skeletal structure gives you a lot of information. We neglect palpation a lot. I don't know why is it that it happens with injections, but even supratrochlear is always going to run through a crack on the bone, either the foramina or a fissure in the bone. You can feel it. And if you put the patient's head down, you're going to see the vessel going up. So there is a lot of information on the topography of the skull that we don't use as much as we could when injecting a risky area, as long as we know at least the main 4 vessels that are non-arbitrary, that we know they're going to be there.
Because vascular occlusion with cannulas do happen, but do you think you can tell by moving the cannula? Like so the question is really how well adhered are the arteries to the surrounding structures? So to the point where if you use moving the cannula as a test, is that do you think that's a fairly reasonable way to tell if it's in a vessel or not? Because you wouldn't expect it to move very easily if it was in a vessel.
Tim, I think we have statistically more vascular accidents with cannula than we have with needles, because in the bridge of the nose area, people just perform these injections more with cannula than they do with needles.
Okay, so, but yeah, so I mean, I think that's possible. But don't you think the size of the occlusion is related to the fact that it's a cannula? If you're injecting more in one spot, but anyway, it's almost...
And statistically too, we do have more reports of injections blocking vasculature in the touch-up, because this the patients mostly, they are very anxious. Aesthetics patients, they want results it's a fast track kind of result, and we tend to want to please them. Most of you, not me. I'm sorry. But we try to please the patients and performing touch-ups within healing time. And this is when we get edema, fighting for space with the injected material, the healing process, and also the touch-up material. And then you're going to have vascular accident that doesn't even reflect the amount of volume that is being injected. So I think
that's an interesting idea, that the swelling from the previous procedure is a risk factor for vascular occlusion.
Definitely, we have most of the accidents come on touch-ups.
Yeah, I can imagine the vessels are more dilated and makes them easier to hit.
There is an inflammatory process. It's competition for space, especially in young people. We don't see a lot of vascular accidents in older patients. There is space in between the layers.
That's interesting. If I think of the VOs I've seen, I would anecdotally that fits. They're mostly on younger people. But I've never thought about why.
There is competition for space. A nasolabial fold, the depth of the fossa pushes the filler away from the piriform entrance, because there is insertion, and the filler is not going to invade. When it does, we have those hypertrophic nostrils that look awful, and they need to be dissolved, because it's fatty tissue, and all the fatty tissue reacts with swelling on inflammatory process. That's a characteristic of fat.
Are you aware of the vessels? This is the problem with cadaver study, but do you think the vessels are smaller in older people? Like your cardiac output goes down.
Not only smaller, we don't have a capillary bed in older patients. We don't have, the capillary bed is poor in older people.
And you can see that on complexion. I suppose I'd never thought about that either, but you can see it on complexion. If you look at a very old face, they're more one color, and they don't have the contrast in their lips.
Structure is gone. You do not have a good collagen matrix, not even to stimulate. If you don't have a good collagen production base, what is the purpose of stimulating collagen where there is no collagen structure at all? It's deteriorated, and so many factors contribute to deteriorating collagen scaffolding. You do have space, however. Older people, you have space between these layers. The superficial fat grows thinner, the deeper fat goes wider, and we lose everything with aging. Reality there is that we lose everything, dignity even, everything, hair, water, collagen, vasculature on the surface, everything. We lose everything with aging, but we do gain space in between the layers, and that's why we have a much safer crowd of patients in people that are a little older.
That's interesting. I actually thought that the blood vessels would take up, if volume loss was significant, that they would take up a relatively larger room. But I hadn't accounted for the fact that blood flow is less, and there's actually less blood in the skin, which makes perfect sense. So that's something I've learned from today. That's really, really helpful.
Imagine that. I'm the one learning from you all the time.